juvenile
Has examination.
Yeah, okay, so the pterygovaginal canal is completely gone on this side, and the pterygomaxillary space is completely widened by the tumor. So that's pretty diagnostic for this tumor, as well as it being a male patient. And the patients usually present with bleeding. They bleed a lot, so when the ENT surgeon biopsies these, they can't stop the bleeding, they pack the nose, and then the first thing they want is an embolization. So here's the angiogram for this patient. Who can tell me which arteries are supplying the tumor? Vidian? No, just have a look where these are coming from. So remember the vidian and the mandibular, primitive mandibular would be coming from the petrous segment. So that is a possible supply, but not in this case. Where's the supply coming from? This is cavernous. That's ILT. So that tells us that the tumor has come right up to the skull base because it's recruiting flow from the carotid through the ILT into the tumor base. Okay. But this is the typical pattern of supply. So it's an injection of the internal maxillary artery, and we get this enormous tumor blush. This is the lateral view. This is the AP view. And you can see the tumor here is right down into the nasopharyngeal space. It's gone right up into the sphenoid, where it's communicating with the sphenopalatine artery of the opposite side. So we know we've got supply from both sides because it reaches the midline. So this gets embolized. We use PVA particles to do that. And then we inject selectively the ascending pharyngeal, because this tumor's reached the back of the pharynx. So it's going to recruit supply from the pharynx. So we've got ascending pharyngeal. Which trunk is this? Neuromeningeal trunk. And then this is the pharyngeal branches, and we've got middle, superior. If we embolize this, what's the possible connection? What's the risk that we have to avoid over-injecting? Yes. So we've got connection with the internal carotid in the foramen of foramen serum. So if we embolize this with particles, we're left with this supply. What's this? So here we've got internal maxillary, transverse facial. What's this artery? No, facial artery would be this one. Facial artery is going to be down by the jaw. So it's a branch of the facial artery. No, lingual, no. Yes. So this tumor has reached the palate, right? So all the arteries that are anastomose around the palate are going to be supplied. So we've taken out the descending palatine artery when we embolize the internal maxillary. We've got now the ascending palatine, the branch of the facial, which is coming up to anastomose the palate over here. What's another supply that could be possible there? We've probably embolized it already. What else anastomoses of the palate? So ascending palatine, descending palatine, ascending pharyngeal, what else?
Sphenopalatine?
Yes, which is the descending palatine branch, right? The accessory meningeal. So the accessory meningeal has branches that supply the eustachian tube, that can also supply the palate. So accessory meningeal is another supply that can be in this area. So once we embolize this ascending palatine artery, So here's just a picture right from the book. Here's ascending palatine, descending palatine, and this one is the accessory meningeal. And this is the palatine anastomosis of the accessory meningeal artery. So we've embolized this. This is our final control. And we left with the supply that's coming from interlateral trunk, and maybe a little bit now from primitive mandibula. Good. Any questions? No, we're exactly on time. So we break for coffee. I think if we put the lights on, I think this is, we're going to stop for a coffee break, but that's the end of the lectures, end of the workshops. So thank you all for sitting through a week of really intense lectures. It's tiring, I know.
Saying goodbye to the ones